Well, hello, everyone, and welcome to CancerSpeak, the official podcast of the American Cancer Society journals. I'm Dr. Courtney DiNardo from MD Anderson in Houston. I'm your host for today's episode. I serve as a section editor of Heme Malignancies for the journal Cancer, and I'm also a clinical researcher focused on the prognostication and development of personalized, effective therapeutics for patients with leukemia and myeloid malignancies. I am very pleased to be joined today by Dr. Anand Bewersdorf, the lead author of a new original article in Cancer that evaluates the impact of novel therapies on the outcomes of patients with post-myeloproliferative neoplasm, post-MPN acute myeloid leukemia, AML, or post-MPN AML, as we'll call it. So, Dr. Bewersdorf, welcome to CancerSpeak, and thank you for joining us today.
Thanks for having me. And on behalf of all my co-authors, I would like to thank the American Cancer Society and the journal and all the peer reviewers for highlighting our work today. As Dr. DiNardo just mentioned, my name is Anand Bewersdorf, and I'm an assistant professor of medicine at Yale. My clinical and research focus is on patients with myeloid malignancies, with a special interest in patients with myeloproliferative neoplasms, or MPNs. And a rare subset of patients with MPNs that's very near and dear to my heart is patients with post-MPN AML, or we also call blast phase MPNs. And so that's where we did our recent study on, and I'm excited to tell you more about that.
Wonderful. Well, thank you. It's great to have you here. And I am also happy to be joined by one of the reviewers of this article, Dr. Anand Patel. Dr. Patel, would you kindly introduce yourself to our listeners as well?
Yeah, absolutely. Thanks so much for having me. So my name is Anand Patel. I am part of the acute leukemia and myeloid malignancy program at the University of Chicago, where I'm an assistant professor of medicine, and I'm a clinical investigator in the space of acute leukemias and myeloid malignancies with a specific interest, much like Jan's, in post-MPN AML, so blast phase MPNs. Very happy to be here.
Perfect. Well, a kind of rare subset of a rare disease, but certainly one where there's a lot of discoveries and science and therapies needed for these patients. So, Jan, I'd like to start with you. Can you take just a few minutes to briefly summarize your article for those who may not have had a chance to read it yet?
To maybe just provide a little bit of background, myeloproliferative neoplasms are what we think are mostly chronic myeloid malignancies. However, a small subset of patients unfortunately progresses to acute myeloid leukemia, or something we call blast phase MPN. And the treatment options for those patients are quite limited. Those patient subsets have an increased frequency of adverse molecular features, and treatment options are limited, leading to a median survival in retrospective studies of around 3 to 6 months. Fortunately, the treatment landscape of AML in general has been really revolutionized in the last years with the introduction of several novel targeted therapies, including BCL2 inhibitors like venetoclax and other targeted therapies, for example, against IDH1 and 2, as well as FLT3. However, if those advances in the treatment of AML in general also translate to patients with post-MPN AML is unclear. And unfortunately, because this is such a rare patient subset and those patients are frequently excluded from clinical trials, our evidence base in this patient population is quite limited. So to answer some of those questions, we used a health records database from the Flatiron Health database to analyze a subset of sizable population of 392 patients with post-MPN AML who were treated in the United States. And the nice thing about the Flatiron Health database is that it's quite a comprehensive database. It includes patients that are treated in community-based practices, but also in academic centers. So it's quite representative of the general patient population. And one of the things we looked at is, one, did the treatment patterns change over time with the introduction of new therapies? And we dichotomized our patient population based on the time of diagnosis. We had one subset of patients that were diagnosed before the approval of venetoclax, and then the other half of the patients diagnosed after the approval of venetoclax. And so what we could see is that with the availability of venetoclax, the number of patients who got intensive induction chemotherapy significantly decreased over time. And at the same time, more patients were treated with what we call lower intensity treatments, which is mostly a combination of HMA or hypomethylating agents in combination of venetoclax. So while we did detect a significant change in the treatment patterns over time, there was unfortunately no improvement in overall survival. The median overall survival in line with other studies was only around 7 to 8 months in our patient population and didn't really change with the approval of venetoclax as well as other targeted therapies. And then a last point I would like to make here is that the only treatment that can potentially cure patients with post-MPN AML is an allogeneic bone marrow transplant. However, getting to transplant and having a successful post-transplant outcome really depends on a number of factors. One is, are we even able to get the disease under control? Are we able to achieve a remission, which is really important to achieve the best possible outcome post-transplant? And then furthermore, patients with post-MPN AML tend to be older. They have other comorbidities that might preclude going to transplant. So one of the interesting takeaways from our study was also that only 15% of patients with post-MPN AML proceeded to a bone marrow transplant. However, among those patients who proceeded to transplant, the median overall survival was 20.5 months, which was significantly longer than what we see without transplant, where it was only 5.8 months. And importantly, we could also show that it didn't really matter how patients got to transplant. Patients with intensive chemotherapy or a lower intensity treatment that were successfully bridged to transplant had comparable outcomes. So I think this really shows a few things. One, we saw a change in the treatment patterns that unfortunately did not translate to outcomes. And we also highlight that probably allotransplant is potentially curative, still only available for a minority of patients. But if you are able to proceed to a transplant, your outcomes afterwards are significantly better. And the type of treatment that you get before going to transplant does not have a significant impact on your post-transplant outcomes. So I think this is more of a status quo description, and that can serve as a call to action. And I think we have various interesting and novel treatments in development in clinical trials that can hopefully move the needle also for this patient subset of patients with AML, as we have seen with other patients.
Perfect. Yeah. So I think, in the world of AML, right, we tend to think about, our younger, fitter patients are getting standard intensive chemotherapy options. And a lot of our patients are older, and many of them are now getting what's considered the standard of care, a hypomethylating agent like azacitidine or decitabine with venetoclax. So I think one of the key kind of points here is that, HMA-VEN has done such a great job for a lot of different AML subsets, but really limited in this population, certainly effective in some subsets. And, in patients who are getting HMA-VEN regimens or intensive chemo for that matter, the goal is always to transition to a transplant, which may or may not be possible in certain patients. So Dr. Patel, tell me kind of just some of your kind of take-home points and your kind of gestalt from going through this paper, and what are you kind of struck by, and what do you think moving forward we should be focusing on?
Yeah, I think, Jan has done such a beautiful job of highlighting the work that his group put into this paper. When I think about kind of what are the salient takeaways, I really like the analysis of looking at outcomes in the pre-VEN and the post-VEN era. And I think that top line takeaway of essentially we haven't moved the needle at all, because the pre-VEN era is really you have intensive chemotherapy, HMA monotherapy, and then you can kind of think about other sorts of treatment approaches. Post-VEN, you have intensive chemotherapy, HMA-VEN, but there's also been a revolution of targeted therapies that are now available for AML. And it seems like even with that kind of increased arsenal of agents, overall survival is still about the same. And I think that really speaks to the fact that we need novel approaches for blast phase MPNs, and borrowing from the AML toolkit isn't going to cut it. I think the other piece that's important is that the conversation around a minority of patients making it to allogeneic transplant, and in large part that may be due to lack of disease control, disease biology. For example, post-MPN AML tends to be enriched with TP53 mutations, so a particularly chemo-resistant subset of myeloid malignancy. You have patients who may not be candidates for transplant due to age and otherwise. And even if patients make it to transplant, your median overall survival is still only about 2 years. And that actually aligns about with what we've seen in previous retrospective work in this space. There was a recent large analysis published that quoted maybe about a third of patients that make it to allotransplant being cured. So thinking about long-term disease-free survival. So lots of work to be done even post-transplant for this patient subset.
Yeah, and I will highlight, just because it's a particular, research interest of mine, there are a subset of the subset of the subset, right, who have IDH mutations, and, certainly being aware of that and utilizing, an effective targeted therapy in that population can be really clinically relevant. I think probably the numbers didn't, reach statistical significance because it was such a small group. I think, as we think about kind of venetoclax as the panacea for all leukemias, not everything is really BCL2 driven. And I think there's been a lot of good research that, the MPNs in particular have more, MCL1, but especially BCL-XL, right? So some of the kind of alternate pathways. So, venetoclax, for those who are not so attuned, is a specific BCL2 inhibitor. So, there are some dual BCL2, BCL-XL or BCL-XL inhibitors that may be kind of a more appropriate avenue of future research. So that's something that I'm certainly excited about. I'll open it up to the two of you. Any last thoughts or things that you're really excited about in this space moving forward?
Yeah, I think both of you mentioned already a key point here, which is the need for better therapies and more targeted therapies. We did have a very few patients who were actually treated with an IDH inhibitor, but that's such a small subset that we couldn't really include them in the analysis in a meaningful way. But it is certainly, if someone has such a targetable alteration, I think it's really important that we harness that. And Dr. Patel has done some important work on this too. And I think ultimately these results are a call to action. Both how can we improve transplant rates and post-transplant outcomes, but also how can we develop better targeted therapies. And I think the field is actually finally recognizing that not all AML patients are the same. And we now have specific trials actually really enrolling patients with post-MPN AML. And I think that's really exciting, because I think we neglect biology to a certain extent by just lumping everyone together. And I think really identifying the biologic drivers of disease and then developing targeted therapies. I think that's where the field has to go.
Yeah, to just add to that, when we think about IDH1 and IDH2 mutations in this patient population, it's about 20 to 25% of patients that have them. And work that our group has done, MD Anderson group, others have shown, is that IDH inhibitors tend to work quite well for patients who have post-MPN AML. And you can see some durable responses even in the absence of an allo transplant. But that still leaves 75% of the patient population where we're really thinking about how do we impact the outcomes for them. So in a mutation agnostic fashion, something that we are currently prospectively investigating in collaboration with the NCI CTEP program is HMA plus the LSD1 inhibitor iadademstat. LSD1 has been a target that's been extensively investigated in chronic phase MPNs and is being looked at in de novo AML. But as of yet, there is not very much clinical data of its use in post-MPN AML. So we have an ongoing study looking at this combination, and we'll have a randomized component to it as well, which ultimately will be the first randomized effort in the space of blast phase MPN. So really, I think speaking to the fact that currently what we have are small prospective single arm studies and real world data to guide us, as there is an increasing recognition that this disease subset needs its own therapeutic interventions outside of what we do for AML. Hopefully, as Jan mentioned, this is kind of the call to action to develop protocols specifically for blast phase MPNs. And really, if there are drugs that have signal, making sure that they are providing benefit beyond our current standard options.
Perfect. Well, thank you so much. I think what really struck me is just, this provides such a nice contemporary natural history, right? That, with our newer therapies, we have still a ways to go, and knowing what our kind of response metrics, our survival metrics are, in order to improve. So I think this is going to be really useful for the MPN and leukemia community, as well as different kind of companies looking to design a trial. What are we trying to beat in terms of expectations for trial design? So I want to thank you so much, both of you, for being with us today and sharing some of your insights in this really kind of important topic and wonderful manuscript. So thank you so much.